This is group 6 with diabetes mellitus type 1. So this is our concept map. So starting at the top in the red box is pathophysiology. Type 1 diabetes is defined as an autoimmune disease. It's caused by glucose not entering the blood cells, and it's due to an insulin deficiency or total loss of insulin. So this is determined by the diagnostic testing, which is the green box on the right. And there's 3 diagnostic tests. There is the random plasma glucose, which is a quick diagnosis to check the glucose in the blood at a random time. There's the fasting plasma glucose test, which is a blood test that's taken to check the glucose when a patient has fasted from 8 to 10 hours. And then the last one is the oral glucose tolerance test, or an OGTT, which is an examination of how well the body absorbs sugar. And this is when a patient is fasted and then will take 75 grams of a glucose fluid or a sugary drink. So back over to the pathophysiology. So this insulin deficiency is due to a destruction of the beta cells in the islets of Langerhans. And so this is caused by the purple box in the left-hand side, the risk factors. This is caused by genes, which are traits passed on from the parent to child, so it's inherited. It's from a virus, so being exposed to a trigger in the environment, which causes these antibodies to then turn on the beta cells. It's caused by family history, or it's caused by age. So most younger people than 20 years old will have type 1 diabetes because it's due to an autoimmune disease. So back over to the red pathophysiology box. So this destruction of the beta cells leads to a decreased tissue glucose utilization. So these lead into more signs and symptoms, but I'm going to continue with the pathophysiology. So this results in a cell breakdown of adipose tissue and protein, results in a liver glucogenesis, and it also results in a loss of muscle mass as muscle cells atrophy or die, which then leads to an increased protein catabolism, which is the breakdown into amino acids. And so this specific step can then further lead into more complications, such as ketoacidosis, acute renal failure, and both of those can then result into diabetic coma. And so there's a lot of other complications that can result from type 1 diabetes, but I'm going to go back to this later. So these pathophysiology area, this then breaks down into some of the signs and symptoms. So the tissue glucose utilization, so this actually can lead to fatigue. And so because the tissue isn't getting enough energy, enough glucose, and so that's our energy, so we become tired. The cell breakdown of adipose tissues and proteins, that leads to weight loss because the body is not getting enough food, so it starts to break down other areas to then generate enough nutrients for itself, which then that leads to, again, fatigue, and both of those can really cause increased hunger. So it makes it feel like we need to eat more because we don't have the energy. And then that liver glucogenesis leads to hyperglycemia, or an increase in blood sugar. And so that hyperglycemia causes a lot more further issues. So it leads to nerve damage. It leads to visual disturbances such as blurred vision, leads to itchy skin, frequent infections, urinary issues, so ketonuria, glycosuria, polyuria, so ketones in the urine, glucose in the urine, and frequently urinating, which then that leads to dehydration because you're now releasing all of these fluids, and that leads to excessive thirst and dry mouth. So back up to the pathophysiology, that increased protein catabolism, so this breakdown of the amino acids, those then make your body very acidic. So then that leads to an upset stomach and nausea and vomiting. And so the way that we can clinically manage this is in the blue box. And so that blue box starts off with the monitoring of our vitals. So we want to assess blood pressure because as the blood thickens, our blood pressure can then increase, and that can cause further damages. Our daily weight, so going into the weight loss, we want to make sure that we're not putting our bodies into DKA, or the diabetic ketone acidosis. The Glasgow Coma Scale, so we want to make sure that, with hypoglycemia, that we are getting enough glucose to our brains. With the hyperglycemia, we want to make sure that we're not going again into DKA. And then we want to also do, of course, the blood glucose monitoring. So we want to make sure that we are within range. So normal range is within 4 to 8 millimoles, but then we also have hypoglycemia, which is the less than 4 millimoles. And then we have the hyperglycemia. So we have that as 11 millimoles postprandial, so after eating, or 7 millimoles or greater, and that's from fasting. And so hyperglycemia can be treated by insulin administration. So insulin consists of either rapid-acting insulin, short-acting insulin, immediate interacting insulin, long-acting insulin, or we can have this mixed insulin, which is a mixture of the two. And so we administer that subcutaneously in the abdomen, the back of the arm, the thighs, the hips, buttocks. We can also do it intravenously. And so a lot more of this is explained in the medication management. So then we have the hypoglycemia, and that's treated by glucose administration. So the body has broken down all this glucose, so now we need more. So we can give that by medication, so per oral glucose, IV dextrose, or foods and fluids, so juice, cordials, lollies, and biscuits. So again, that's explained in this medication management for both glucose and insulin. So glucose, like I said, we have the oral, which is the glucose gel for a conscious patient, and then also the foods and fluids for another conscious patient as well. So these are fast-acting carbohydrates, so fruit juice, candies, glucose tablets. And so we want to avoid giving fat and protein because those slow down the digestion and the processing of this glucose. We can also give it IV administration. So the dextrose administration is for the long term when the blood glucose levels drops for hypoglycemia. So we're really trying to keep a balance between hyper and hypo. And so that we could also give it through injection as well. If the patient's unable to safely swallow, we may be able to give it through a subcutaneous or an intramuscular injection. So these are per hospital policy, and the doctor has to have provided an order for these. So then we have the insulin administration as well for the hyperglycemic. And so we have rapid acting, which is Novorapid, Humalog, or Apidra. So these fast acting, they take about 2 to 5 minutes to 20 minutes to work, and then they peak at about 1 to 3 hours, and they last up to about 5 hours. And eating must be immediately after injection, and the only insulin that can be delivered intravenously or subcutaneously is the rapid acting. We have short acting, which is Actirapid or Humulin R, and these begin within 30 minutes after injection, and we want to be given before they're eating. And it peaks at about 2 to 5 hours, so it hits their maximum, and then it lasts up to about 8 hours. And then we also have the intermediate acting, which is the Humulin NPH. That starts working at about 60 to 90 minutes after injection. It hits its maximum at about 4 to 12 hours, and it lasts for about 16 to 24 hours within the body. And then we have our long-acting insulin, so Lantus, slow release, and it it lasts until about 18 to 24 hours of effect. And then we have our mixed, so Novamix, which is a predetermined amount of rapid-acting and short-acting insulin with an intermediate-acting insulin. So back into the clinical management, we have next our skin assessment. And so we want to monitor the skin for any wounds and pressure area care because the glucose prevents any nutrients from getting to the skin because it becomes very viscous and hard for it to get there. So we want to make sure that we're monitoring and caring for these wounds and that they're actually healing. We also want to monitor and care for feet in any peripheral areas, but mostly the feet because, again, because this glucose is making the blood more viscous, it doesn't allow it to get to these peripheral areas, and it causes a lot of nerve damage and less nutrients within the skin, which then leads to nutrition. So we want to make sure that we're feeding the patient appropriately, which will then in turn help the skin to heal itself. And so with the nutrition, we monitor it by a food and fluids chart, so we can monitor what goes in and out of the body, as well as through diet orders. So we want to make sure that these have a good balance in glucose breakdown. We also want to educate the patient. So we can refer them to a general practitioner who's going to view that patient as a whole, the optometrist, which could help with any eye issues, which we'll get into a little bit later, and counseling services as well, because if this is a newly diagnosed, it can be very hard on a patient because of how life-threatening some of the complications can be. And it's not just on the patient, it's also on the family. So it's good to have counseling services involved. We also want to refer them to the dietitian because, again, that leads to the nutrition. And so we want to make sure that the patient is not only getting the appropriate nutrition at home, in the hospital, but also at home. And then we also have the podiatrist. So the podiatrist will help to monitor any feet issues. So if an ulcer starts to develop on the foot, that it's not going to then lead to a potential amputation. And then the last one is the endocrinologist and the diabetic educator, which helps with both the hypoglycemic and hyperglycemic and keeping them within a normal range. But we also want them to see the patient outside of the hospital as well, so then that way the patient knows that they're managing their diabetic condition well. And so the reason why we want to keep this education is because it prevents any sort of complications. So this complications on the left-hand side in the red box is, we talked about the ketone acidosis and the acute renal failure, as well as the diabetic coma that can lead to. But it can also lead to heart disease. It can lead to kidney disease because the kidneys are unable to filter out. It basically becomes clogged and it's not able to filter any more of the glucose. Blindness because the blood vessels are so full and the nerve damage that the eyes begin to go. Limb amputation, which we talked about from wound healing, it becomes necrotic. Persistent infection, oral health, lipohypertrophy. So the lipohypertrophy is if the administration is in the same spot, these little fat areas develop and ruin the area, as well as foot problems, which we had talked about earlier. Type 1 diabetes is the total absence of insulin, which is a hormone responsible in regulating glucose in the body. Type 1 differs from type 2, where the insulin loss is induced by the person's own immune system, and where the body attacks itself accidentally thinking it's foreign. And this occurs on the insulin-producing beta cells within the pancreas. So these beta cells, like the ones seen on the right, are in the islets of Langerhans, and that's responsible for producing the insulin. So because there's an absence in insulin, glucose begins to remain in the blood since there is no breakdown occurring. And it begins to block blood vessels as it quickly becomes more viscous and transportation to the brain, muscles, and liver become more difficult. And so the liver detects less glucose in the blood. So it begins to signal to release more glucose that it has stored in itself back into the blood, despite the fact that there's already a high concentration. So the adipose tissues are also being blocked by receiving glucose. And the adipose tissues help the body create more energy, which breaks down to free fatty acids, which the body can then use for energy. So this results to significant and unhealthy weight loss as the body starts breaking down the fat at a rate that's way too fast. And so the liver processes fat into fuel called ketones, which causes the blood to become acidic. And so because the blood is trying to maintain the small amount of glucose it thinks it needs for the brain and other organs, it begins to increase the protein catabolism, which then breaks down into amino acids, which ultimately means the body is performing a muscle breakdown as there's minimal fat left to consume. And so if this is left untreated for too long, it can become a complication known as diabetic ketoacidosis, or DKA, where the body acts like it's starving of glucose despite high presence of glucose in the blood, which results in lethargy and fatigue from all the acid that's building up in the body. So then the kidneys also filter the blood, which are overwhelmed with too much glucose that spills out into the urine called glucosuria. And because the glucose is osmotically active soluble, it draws water with it. And this leads to polyuria or frequent urination, which results in dehydration because too much water is being lost, which then triggers frequent thirst as the body is losing all this water. So the body tries to compensate, but it cannot cope. It's not known exactly why type 1 diabetes occurs, but it is thought that some people are born with a genetic predisposition to the disease, or it's from an unknown cause and triggered by an environmental factor, that's some sort of virus or toxin, which leads to the production of antibodies and T cells. Some people have certain genes that are passed down from parent to child that make them more likely to develop type 1 diabetes. However, some people may have a parent, brother, or sister with type 1 diabetes, but not be diabetic themselves. Diet and lifestyle habits don't cause type 1 diabetes like it does with type 2. And you can get type 1 diabetes at any age, but it's more likely to develop when you're a child, teen, or young. There are signs and symptoms to recognize for those with type 1 diabetes. While some of these signals may be subtle, they can become severe. Some of the signs and symptoms can include increased hunger, since glucose from the blood cannot enter the cells due to the lack of insulin or insulin resistance, so the body can't convert the food you eat into energy. And that lack of energy then causes an increase in hunger. Dry mouth from dehydration and increased glucose drawing the water away, upset stomach from the increase in ketones and acidic levels, frequent infections of the skin, urinary tract, or vagina with the weakening of the immune system, excessive thirst, frequent urination, weight loss, fatigue, visual disturbances such as blurred vision from damaged blood cells due to the viscous blood, nausea and vomiting, itching skin from the nerve damage in the outer layers of the skin, which is also known as neuropathy. There are three main types of testing for type 1 diabetes. There's the random plasma glucose test, which you can have blood drawn at any time regardless of fasting or recently eating, as it will not impact the test. A blood glucose test measurement equal to or greater than 11 millimoles will indicate that you may have diabetes. You'll need to have further test results confirmed on another day through another random test or by taking a fasting plasma glucose test or an oral glucose tolerance test, no GTT. There's the fasting plasma glucose test, which can be taken after you have not eaten any food or drinking anything except for water for the last 8 hours. A glucose test measurement equal to or greater than 7 millimoles indicates that you may have diabetes. Diabetes is not confirmed until 2 separate fasting plasma glucose tests have occurred. Then there's the oral glucose tolerance test. So to test this, the person will be asked to not eat or drink any food except for water for 8 hours, and then drink a liquid containing a known amount of glucose, usually about 75 grams. And your blood is drawn before drinking the glucose mixture and then 2 hours later. You'll be asked to refrain from eating until the test is completed, and then a test measurement equal to or greater than 11 millimoles indicates that you may have diabetes. And so there are some other tests located on this slide as well that are not as commonly used as these top three to diagnose diabetes. In order to prevent further complications that can occur with type 1 diabetes, clinical management must be performed. First, it's critical to monitor vitals. It's important to measure all vitals, but specifically blood glucose levels to ensure that the patient is not in hyper or hypoglycemia, blood pressure due to the thickening of the blood and the stress it can produce on the small and narrow vessels, daily weights for recognition of DKA signs and symptoms, and GCS indicating brain glucose changes. Glucose administration will need to be performed if the patient is becoming hypoglycemic, and following all hospital policies and doctor's orders, it will be given via foods and fluids if the patient is conscious and able to swallow, glucose gel for quick effect, IV administration, or injection. Insulin administration can be given if the patient is hyperglycemic or for prophylaxis, and it can be given on a fixed dose, which is a set amount of insulin regardless of the factors of BGL or food, or it can be given on a sliding scale, which is more dependent on the BGL and food. But there's more about insulin on the next few slides. Then there's education and referrals. Diabetes educators and endocrinologists need to be involved. And so if this is not a new diagnosis, the patient should be familiar with their diabetes management. But it's still important to provide education to that patient regarding their diabetes, treatment, and its complications, as well as keeping the diabetes educator and endocrinologist informed about the patient's condition and making sure that they visit for further information. We also want to have the dietitian involved. So while type 1 diabetes is not induced by poor lifestyle management like type 2 can be, the implications of healthy eating and glucose levels remain the same for both. It's important that the patient education occurs on how to choose healthier options when eating. The podiatrist, so complications can occur at the most peripheral areas within the patient, but feet have the highest complication, being the most distal part of the body. So a patient should be getting regular visits from their podiatrist as there's a high risk foot ulcers and further amputations. The optometrist, so as the glucose levels put pressure on the blood vessels, vision disorders and blindness can occur, so regular visits to help identify these issues early can help prevent complications. Then there's the GP. The general practitioner helps to provide a holistic view of the patient's well-being and not just a view of the diabetic concerns, and ensures that all other complications with the diabetes are being managed together appropriately. Counseling services. So diabetes, especially newly diagnosed, can be difficult on mental health as it requires lifestyle changes that others may not have to go through. And it can result in life-threatening complications, which can place stress not only on the patient, but their families and friends as well. We also want to do a skin assessment. So monitoring and caring for wounds, monitoring and caring for feet and pressure area care, These are all things that because the glucose is preventing a lot of the nutrients from getting in the skin, it delays healing. And so we want to make sure that we're monitoring this stuff and caring for them. And then nutrition is just like the dietitian coming. We want to make sure that while the patient's in hospital, that they're getting the appropriate food that is needed to help, again, provide nutrients to the skin and to the body. So we also want to monitor any foods and fluids that are going out through a fluids chart, as well as making sure that we're ordering the appropriate foods through a diet order. Unlike with type 2 diabetes, insulin cannot be given in tablet form, such as metformin, as it would be destroyed in the stomach and would not convert glucose into energy. Injections is the most conventional form, as it involves the syringes, and is usually injected in the subcutaneous tissue of the upper arm, interior lateral aspects of the thigh, buttocks, and abdomen. The abdomen absorbs the insulin the fastest and is essential to rotate injection sites to avoid lipohypertrophy, or lumps under the skin caused by fat buildup at the constant injection sites. There's also the insulin pens, which have two basic forms, which are disposable and reusable. And then there's the insulin pump, which is a small programmable device that holds a reservoir of insulin, and it is programmed to infuse insulin into the body over a rapid period of time. There are different types of insulin that we can give. There's fast-acting insulin, such as Novorapid and Humalog, which show effect almost immediately after injection. It hits its maximum efficacy about an hour after it's been injected, but continues to last up to 3 to 5 hours. There's short-acting insulin, Actirapid and Humulin R, which begin to work within half an hour, and it peaks about 2 to 4 hours and lasts for 6 to 8 hours. There's an intermediate insulin, such as Humulin NPH, that has either protamine or zinc, and it's added to delay its action, and it begins to work about an hour and a half after injecting and lasts in the body for almost 24 hours. Then there's a mixed insulin, such as Novamix, which contains a pre-mixed combination of either a fast-acting or short-acting insulin and an intermediate-acting insulin. And this makes it easier for injecting by giving two types of insulin within one injection. Then there's the long-acting insulin, such as Mellitus, which lasts for up to 24 hours. If diabetes is left undiagnosed for too long, or if it's not managed appropriately, this can lead to severe and life-threatening complications, some of which we've already discussed. So there's heart disease, the high glucose in the bloodstream that can damage the arteries, causing them to become stiff and hard. Kidney disease, because the kidneys can't filter out the glucose anymore because they've been blocked and stopped working. Blindness, due to the blood vessels in the capillaries being filled with this viscous blood. Foot problems, limb amputations, persistent infections, because they're more susceptible to developing infections as high blood sugar levels can weaken the patient's immune system. The oral health, as bacteria begin to grow inside the mouth, it can lead to plaque buildup and possible gum disease, and the lipohypertrophy. And so while type 1 diabetes is not reversible, it is treatable. So in order for a patient to have a normal quality of life, it is important to get the patient the appropriate resources and education to help manage this condition.